patient with the above rhythm is a 62-year-old woman who has generalized weakness, shortness, breath, and nausea. Her blood pressure is 86/50. Her pulse rate corresponds to the EKG rhythm 50 and irregular. Respirations are 24 breaths per minute with normal tidal volume. This is a secondary type 1 and it's symptomatic bradycardia, so I'm going to make sure airway's open. I'm going to put her on a non-rebreather at 15 liters. I'm going to check her pulse and make sure it corresponds. I'm going to start an IV, start pushing 500 milliliters of fluids, do a sample history, physical exam, pulse ox, capnography, blood pressure. Then I'm going to push 0.5 milligrams of atropine. I can begin pacing the patient and I can give 2 to 10 micrograms per kilogram per minute of dopamine and do a 12 lead. Patient with the above rhythm is a 56-year-old man who complained of significant chest pain and palpitations before calling 911. At this time, he is confused and lethargic with the following vital signs: blood pressure 80/40, pulse rate corresponds to the EKG rhythm 180 and irregular. Respirations are 22 breaths per minute with normal tidal volume. So this is AFib and it's unstable, irregular, narrow, complex tachycardia. I'm going to make sure the airway's open. I'm going to put him on a non-breather at 15 liters, check his pulse and make sure it corresponds. I'm going to start an IV and push 500 milliliters of normal saline. I'm going to do sample history, physical exam, pulse ox, capnography, vital signs. Then, because he's unstable, I'm going to cardiovert him starting at 120 joules, and then we can move up in a stepwise fashion, so 200, 300, 360 joules. We can try to do vagal maneuvers to try to slow his heart rate down, and if that doesn't work, we can push 0.25 milligrams per kilogram of diltiazem, and we can cardiovert once again. This patient is a 65-year-old woman who has complained of generalized weakness and depression for the last 2 weeks since her husband died. She was found unconscious lying in the garden by a family member. Her daughter thought she was breathing at first, but then started compressions just before your arrival when it became obvious the patient was dead. Quick look shows the rhythm above the patient is pulseless and apneic. So this is an accelerated idioventricular rhythm and it's PEA. So we're immediately going to start compressions and start handling the airway. Start with a basic airway, move to an advanced airway with supplemental oxygen. Continuing compressions, we're going to start an IV, start pushing 500 milliliters normal fluid, get a sample history, and do a physical exam. We can push epinephrine 1 milligram, 1 to 10,000 every 3 to 5 minutes, and continue with CPR. And we can rule out the H's and D's. The patient with the above rhythm is a 45-year-old man who has chest pain that is described as a pressure a 9 on a scale of 1 to 10 radiating to the left shoulder. It has been constant for the last 20 minutes. He also complains of shortness of breath and nausea. His blood pressure is 140/70. Pulse rate corresponds to the EKG rhythm 60 to 68 and irregular. The ectopy occurs approximately 8 times a minute. Respirations are 24 breaths per minute with normal tidal volume. So this is a normal sinus rhythm with PVCs. And he has cardiac chest pain. So we're going to start out with the airway, make sure the airway is open, put him on a non-rebreather at 15 liters, check his pulse, make sure it corresponds. We're going to start an IV and start pushing 500 milliliters of normal saline. Sample history, physical exam, pulse ox, capnography, vital signs. Then we are going to start giving Mona drugs for the chest pain. So we already gave him oxygen, so we're going to give 324 milligrams of aspirin, and then we can give 0.4 milligrams of nitroglycerin, and that has a max of 3 doses. And then we can give 2 to 4 milligrams of morphine, and that has a max of 10 milligrams. And do a 12 lead and a fibrinolytics checklist.